Acute kidney injury or AKI. For this session, we're going to talk about the definition of acute kidney injury, classification of acute kidney injury based on anatomic location of the initial injury, the pathophysiology of acute kidney injury, clinical presentation of acute kidney injury, and the diagnosis of acute kidney injury. In the 1940s, the old term was acute renal failure or ARF. The term acute kidney injury was introduced in 2004 to reflect the full spectrum of ARF. In terms of pathophysiology, acute kidney injury is defined as the rapid decline in glomerular filtration rate resulting in disturbance of renal physiological functions, namely impairment of nitrogenous waste product excretion, loss of water and electrolyte regulation, and loss of acid-base regulation. A simplified clinical definition of acute kidney injury refers to increased blood urea nitrogen or BUN, increase in serum creatinine, and decrease in urine output. Since the introduction of the term acute kidney injury in 2004, there have been over 35 definitions of acute kidney injury. You will read about AKIN criteria, rifle criteria, etc. To standardize AKI definition, KDIGO in 2012 came up with a definition and staging that uses serum creatinine and urine output criteria. If you notice, it includes a 0.3 mg per deciliter or 26.5 micromolar per liter serum creatinine increase from baseline criterion that is specifically applicable to pediatric AKI. If in previously healthy children, the baseline serum creatinine is unknown, KDIGO recommends to use a presumed GFR baseline of 120 mL per minute per 1.73 meters squared. Or an alternative approach, using a published minimum and maximum normative serum creatinine values for age and gender. The imputed age and gender-based serum creatinine norms have been successfully applied as a surrogate baseline to detect pediatric AKI in both the hospitalized and in the community settings. Modifications also allow for a child with estimated GFR less than 35 mL per minute per 1.73 meters squared to be included in stage 3, in contrast with the adult criterion of more than 4 milligrams per deciliter serum creatinine, which would be unusual in infants and young children. You can see also that extension of the diagnostic time frame for a serum creatinine rise to 7 days allows for the inclusion of patients with late onset AKI. The KDIGO AKI criteria have been validated in hospitalized children with both critical and non-critical illness. Clinically, the most widely used laboratory finding to make the diagnosis of AKI remains an elevated or rise in serum creatinine. AKI can be classified based on the anatomic location of the initial injury. It can be prerenal, it can be intrinsic, and it can be postrenal AKI. If there is an interruption of perfusion to the kidneys, it usually results in prerenal acute kidney injury. Ultrafiltration occurs at the glomeruli, forming an ultrafiltrate which subsequently flows into the renal tubules. Glomerular injury resulting in disruption of glomerular filtration rate is one of the major causes of intrinsic acute kidney injury. Reabsorption and secretion of solute and/or water from the ultrafiltrate occurs within the tubules. Acute tubular necrosis due to nephrotoxins or hypoperfusion is one of the major causes of intrinsic acute kidney injury. The final tubular fluid, the urine, leaves the kidney and sequentially drain into the renal pelvis, ureter, and bladder from which it is excreted through the urethra. Postrenal acute kidney injury is due to obstruction of urine anywhere along the urinary tract in a single kidney, and in patients with two kidneys, bilateral obstruction usually occur at the bladder or the urethral level. Decreased perfusion to the kidneys, and as a consequence, a reduction in glomerular filtration rate can cause prerenal AKI. This occurs due to following pathogenetic mechanisms. It can be due to true volume depletion, example, in cases of bleeding such as during surgery or trauma. It can be due to intestinal loss such as in the case of gastroenteritis. It can be due to excessive cutaneous loss such as in the case of severe burns, or excessive urine loss such as in patients with diabetic ketoacidosis. Prerenal AKI can also be a result of effective renal hypoperfusion, such as in the case of decreased arterial pressure, such as in patients with heart failure. It can also occur when there's systemic vasodilatation due to decreased intravascular volume despite normal or increased total body water, such as in the case of septic shock, neurogenic shock, or cirrhosis. It can also be due to intrarenal vasoconstriction. Medications such as NSAIDs, ACE inhibitors, ARB, calcineurin inhibitors can also be a cause of prerenal AKI via a mechanism of intrarenal vasoconstriction. Hepatorenal syndrome and cardiorenal syndrome can also be a cause of prerenal AKI. Prolonged renal hypoperfusion is the most common underlying etiology for intrinsic AKI. However, in critical care settings, intrinsic AKI is frequently multifactorial in etiology with concurrent ischemic, nephrotoxic, and septic insults that can exacerbate the severity of kidney injury. Intrinsic acute kidney injury can be classified further into disorders that affect the kidney vasculature, the glomerular, the tubule, and the interstitium. Causes of tubular and interstitial disease in children include infections and adverse reaction to drugs. Common drugs associated with tubulointerstitial disease include NSAIDs, aminoglycosides, amphotericin B, calcineurin inhibitors, and cisplatin. However, iodinated contrast does not appear to be associated with AKI in hospitalized children with eGFR greater than or equal to 60 ml per minute per 1.73 meters squared. Intrinsic acute kidney injury can also be induced by this release of endogenous nephrotoxins such as myoglobinuria due to rhabdomyolysis and hemoglobinuria due to intravascular hemolysis. Bilateral urinary tract obstruction, or obstruction of the urinary tract of a solitary kidney, can cause post-renal AKI. Intrarenal stones, crystals, and clots, or extrarenal obstruction such as in the case of neurogenic bladder, hypertrophic prostate, retroperitoneal fibrosis, cervical, prostate, or bladder cancer can cause post-renal AKI. There are also medications that cause urinary retention, causing post-renal AKI. Please note that children with chronic kidney disease from uncorrected congenital obstructive uropathies remain at significant risk of AKI from ischemic, septic, and nephrotoxic insults. How does the kidney maintain glomerular capillary perfusion pressure and glomerular filtration rate in the setting of prerenal AKI? So in the patients with decreased arterial blood volume, the release of vasoactive agents norepinephrine and angiotensin II is one of the main systemic compensatory mechanisms that maintain perfusion to the brain and heart by normalizing intravascular volume and blood pressure, but in effect, it diminishes renal perfusion and as a consequence reduces GFR. So what the kidney does, there are several renal compensatory mechanisms that attempt to maintain GFR in patients with decreased renal perfusion. The most effective of these renal compensatory mechanisms involve the intrarenal generation of vasodilatory prostaglandins. So if you give NSAIDs, this will inhibit the response and can therefore precipitate AKI even when following appropriate dosing. The risk of AKI is higher when these agents are used in setting of renal hypoperfusions. There are two common pediatric scenarios in which this occurs. One is the giving of indomethacin for closure of patent ductus arteriosus in neonates and the use of ibuprofen in febrile children with hypovolemia due to gastroenteritis. The second mechanism involves intrarenal angiotensin II, which constricts both the afferent and efferent arterioles. The effect is greater in the efferent arteriole, leading to increased hydrostatic pressure across the glomerulus and maintenance of GFR. So if you give angiotensin-converting enzyme inhibitor or angiotensin receptor blocker, this will block this compensatory mechanism. The third mechanism is the myogenic autoregulation. Myogenic autoregulation refers to the unique ability of the afferent arterioles to vasodilate in response to decrease in lateral stretch caused by hypoperfusion. Calcineurin inhibitors such as cyclosporine and tacrolimus that are commonly used for immunosuppression following kidney transplants can interfere with this myogenic response. Molitoris proposed a mechanistic classification that delineates four distinct phases in acute kidney injury. The first is the initiation phase. This is followed by the extension phase, then the maintenance phase, and lastly, the recovery phase. Patients at high risk for ischemic AKI include those with a reduced effective arterial volume resulting in prerenal azotemia. Numerous ischemic insults, whether alone or in synergistic combination with nephrotoxins, initiate epithelial and vascular cell injury, resulting in an extremely rapid decline in GFR, appropriately termed the initiation phase. The initiation phase is immediately followed by a phase that has recently been termed the extension phase. During the extension phase, multiple interrelated events lead to worsening of epithelial and endothelial cell injury and cell death, primarily in the corticomedullary region of the kidney. The maintenance phase represents a phase of stabilization of injury and subsequent correcting events leading to cellular repair, division, and redifferentiation. This sets the stage for improved epithelial and endothelial cell function and recovery of GFR during the recovery phase. This slide illustrates the mechanistic classification of the phases of acute kidney injury at the cellular level. Let's talk about presentation of AKI. In children, AKI can present in several different ways. It can present with signs and symptoms that result directly from alteration of kidney function. This include edema due to progressive fluid accumulation. It can be decreased or no urine output. It can be gross and microscopic hematuria and or hypertension. In these patients, there is often a known etiologic factor that predisposes the child to AKI, such as shock or heart failure, or a preceding streptococcal infection seen in patients with post-streptococcal glomerulonephritis. Laboratory monitoring of at-risk patients identify alterations of kidney functions. Elevation of serum creatinine and or BUN or abnormal urinalysis can just be the presentation of AKI. For example, Ongoing monitoring frequently will identify a rise in serum creatinine in children post-cardiac surgery, those undergoing treatment for malignancy, or those receiving potentially nephrotoxic agent. AKI identified by laboratory testing is common in critically ill patients with multi-organ failure or dysfunction. In these patients cared for in the intensive care setting, acute kidney injury is associated with mortality and significant morbidity. In addition to an elevated serum creatinine, disruption of kidney function may result in hyperkalemia. Hyperkalemia can be detected in the serum or can be manifested as distinct ECG changes. These include, in sequence according to the severity of hyperkalemia, tall peak T waves, prolonged PR interval, flattened P waves, widened QRS complex, ventricular tachycardia, and fibrillation. There are several factors that may contribute to hyperkalemia in patients with AKI, one of which is reduced GFR. Next is decreased tubular secretion of potassium. Tissue breakdown with release of intracellular potassium, such as in the case of patients with significant tissue breakdown having rhabdomyolysis, hemolysis, and tumor lysis syndrome. Another factor can be metabolic acidosis, which results in transcellular movement of potassium. Take note that each 0.1 unit reduction in arterial pH raises the serum potassium by 0.3 milliequivalents per liter. The symptoms of hyperkalemia are nonspecific and may include malaise, nausea, and muscle weakness. Dysnatremias are also observed in AKI. Hyponatremia is a common laboratory finding and generally is due to dilution from fluid retention and/or administration of hypotonic fluids. Less common causes of hyponatremia include sodium depletion, which we call the hyponatremic dehydration, hyperglycemia, wherein the serum sodium concentration decreases by 1.6 milliequivalent per liter for every 100 milligrams per deciliter increase in serum glucose above 100 milligrams per deciliter, and pseudo-hyponatremia. Hypernatremia is less common in children with AKI. It is usually due to hypernatremic dehydration causing prerenal failure, excessive sodium administration, example, excessive sodium bicarbonate administration, and or the inability to excrete a sodium load. A high anion gap metabolic acidosis is also common in AKI, and this is secondary to the impaired kidney excretion of acid and reabsorption and regeneration of bicarbonate. Acidosis is most severe in critically ill children with shock, sepsis, or impaired respiratory compensation. Low calcium or hypocalcemia is commonly encountered in AKI. This is due to increased serum phosphate and impaired kidney conversion of vitamin D to the active form. Hypocalcemia is most pronounced in patients with rhabdomyolysis. Metabolic acidosis increases the fraction of ionized calcium. This is the active form of calcium. Therefore, it is important that the clinician is aware that rapid correction of metabolic acidosis with bicarbonate therapy can decrease the concentration of ionized calcium and precipitate symptoms of hypocalcemia. So you'll see the patient as having tetany, seizure, and cardiac arrhythmias. Hyperphosphatemia in AKI is primarily due to impaired kidney excretion and can contribute to hypocalcemia. Hyperphosphatemia is most pronounced in patients with severe tissue breakdown, such as in the case of tumor lysis syndrome or rhabdomyolysis. The current diagnosis of AKI is made clinically based on the presence of characteristic signs and symptoms and laboratory findings indicative of an acute change in kidney function. As mentioned earlier, and just to reiterate, the signs and symptoms include edema, fluid overload, decreased or no urine output, gross hematuria, and/or hypertension. And for the laboratory findings, you will see elevated or rising serum creatinine. Abnormal urinalysis may also provide support for acute kidney injury. Further evaluation is generally focused on identifying the underlying cause and/or contributing factors of AKI. The most common laboratory test used to identify reduced glomerular filtration rate as an indication of AKI is serum creatinine. As noted previously, serum creatinine only accurately reflects GFR in patients with stable kidney function. However, in most clinical settings of AKI, the exact knowledge of GFR is not required. What is clinically important is whether there is a reduction in GFR due to kidney injury, which is reflected by an increase in serum creatinine. An abnormal urinalysis provides supportive diagnostic evidence for AKI. However, in patients with prerenal AKI, the urinalysis may be normal. In contrast, patients with intrinsic AKI, particularly those with glomerular disease or acute tubular necrosis, commonly will have hematuria and/or proteinuria. Thus, a normal urinalysis does not preclude the diagnosis of AKI. Urinalysis is often helpful in identifying the underlying cause of acute kidney injury. Because serum creatinine is often delayed and imprecise tests for AKI, research has focused on identifying biomarkers that accurately predict acute kidney injury in early stages of injury. Novel biomarkers such as neutrophil gelatinase associated lipocalin or NGAL, kidney injury molecule 1 or KIM1, interleukin 18 or IL-18, fibroblast growth factor 23 or FGF23, insulin growth factor binding protein 7 or IGF-BP7, and tissue inhibitor of metalloproteinases 2 or TIMP2 show promise in both their diagnostic and prognostic utility in the setting of AKI. This may allow for early intervention prior to the onset of serum creatinine rise, severe metabolic derangement, and fluid overload. However, future studies are needed to establish whether any of these markers will provide beneficial clinical guidance in the diagnosis and management of AKI in children. A study that came out in 2011 showed some high-performing biomarkers for AKI in children. So you see here serum cystatin C and urine NGAL. Once the diagnosis of known or suspected AKI is made, further evaluation is focused towards identifying the underlying cause. So you do a very good history and physical examination. The initial history is directed towards uncovering an obvious risk factor or cause for AKI. The following historical findings are often indicative of underlying etiology. Asked about a short duration of vomiting, diarrhea, decreased oral intake associated with decreased urine output, and this will suggest prerenal AKI. Asked about the history of bloody diarrhea 3 to 7 days prior to the onset of oliguria. This may suggest hemolytic uremic syndrome. Asked about the history of pharyngitis or impetigo a few weeks prior to the onset of gross hematuria or edema, which suggests post-streptococcal glomerulonephritis. In hospitalized patients, Nephrotoxic medications or periods of hypotension are associated with intrinsic AKI. Other systemic complaints, for example, fever, joint complaint, and rash, may be seen in patients with autoimmune diseases or vasculitides such as immunoglobulin A vasculitis, which we formerly termed as henoch-Schönlein purpura, or systemic lupus erythematosus. A diligent search for all drugs and medication ingested is especially important even when another obvious cause of AKI is evident. For physical examination, it is very important to measure the blood pressure. Assess the patient for edema, recent weight gain, and signs of systemic disease such as rash or joint disease. Signs of volume depletion must be elicited, such as dry mucous membrane, tachycardia, decreased skin turgor, orthostatic falls in blood pressure, and decreased peripheral perfusion, which are indicative of prerenal AKI. Edema may be present in children with nephrotic syndrome or glomerulonephritis. Rash is commonly seen in children with AKI due to IgA vasculitis, or formerly called HSP, interstitial nephritis, and the acute onset of systemic lupus erythematosus, or SLE. Also look for enlarged palpable kidneys because it can be an indication of renal vein thrombosis. An enlarged bladder may suggest urethral obstruction. So do a very good abdominal physical exam. Serial assessment is essential, especially for critically ill children in whom a fluid overload of more than 10% above their admission weight is independently associated with increased morbidity and mortality. This is especially true in children with AKI requiring kidney replacement therapy, in whom mortality increases by more than 8 times with a fluid overload of more than 20%. As illustrated here, the assessment of fluid overload includes altered mental status, hepatojugular reflux, orthopnea, second or third space fluid sequestration, pitting edema, altered capillary refill. Also, take note of the cumulative fluid balance, which is usually raised, weight gain, and increased jugular venous pressure. What are the laboratory tests and kidney imaging that may be useful in determining the underlying etiology of AKI? We have urinalysis, fractional excretion of sodium, which differentiate prerenal versus intrinsic renal AKI, and kidney ultrasound, and we will discuss this in detail. The urinalysis is often helpful in determining the underlying cause of AKI, as characteristic findings are suggestive of certain disease processes. 1. Look at the urine-specific gravity. The loss of concentrating ability is an early and almost universal finding in acute tubular necrosis with a urine-specific gravity below 1.010. If the urine-specific gravity is greater than 1.020, it is suggestive of prerenal disease. Another thing to look for is the urine osmolality. This is a more accurate measure of concentrating ability of the kidney. Patients with acute tubular necrosis generally have urine osmolality below 350 milliosmol per kilogram, while patients with prerenal disease usually have values above 500 milliosmoles per kilogram. Urine sediment with muddy brown granular casts and tubular epithelial cell casts is highly suggestive of intrinsic AKI or ATN. Red cell cast is diagnostic of glomerulonephritis. Shown here is a photomicrograph of red cell cast. You have your phase contrast image of a dysmorphic RBC and a scanning image of a dysmorphic RBC. Pyuria with white cell, granular, or waxy casts are suggestive of tubular or interstitial disease, or UTI. White cell casts or white cells may also be seen in acute glomerulonephritis. Shown here are photos of WBC casts, waxy, and fine granular casts. These are the tests to distinguish between prerenal and intrinsic acute tubular necrosis. One is the fractional excretion of sodium, or we usually call as FeNA, fractional excretion of urea, Fe urea, or the BUN creatinine ratio. Fractional excretion of sodium is commonly used laboratory test to differentiate between prerenal AKI and intrinsic disease due to acute tubular necrosis. Fractional excretion of sodium is calculated from measured concentration of urinary sodium and creatinine and plasma sodium and creatinine, the formula as shown here. Fractional excretion of sodium is a direct measurement of the kidney handling of sodium, which is similar in children and adults. There are calculators available for fractional excretion of sodium, which is expressed either using the standard units or the international units. Fractional excretion of sodium values in children that differentiate prerenal AKI from ATN are the same as those used in adults. How do we interpret the results of FeNA? So if the FeNA is less than 1%, it suggests prerenal AKI. This means that reabsorption of almost all the filter sodium represents an appropriate response to decreased renal perfusion. FeNA greater than 2% suggests ATN, while FeNA between 1 and 2% is non-diagnostic. How about in neonates? Neonates, especially the preterm infants, the sodium reabsorption is decreased. As a result, the fractional excretion of sodium cutoff values that differentiates prerenal from ATN in neonates are higher. In term infants, the fractional excretion of sodium is usually below 2% in prerenal AKI and usually greater than 2.5% in ATN. In preterm infants, fractional excretion of sodium cutoff values increase with decreasing gestational age, although it is unclear how helpful fractional excretion of sodium is in differentiating between prerenal disease and acute tubular necrosis. FeNA cannot be applied to all cases of AKI, so limitations in the use of FeNA include previous fluid administration, diuretic therapy, or if the AKI is due to contrast nephropathy or pigment nephropathy. In cases where we cannot use or apply the fractional excretion of sodium, we use the fractional excretion of urea. This has been proposed as a more accurate determinant of prerenal AKI, especially in patients receiving diuretics. Patients with prerenal AKI generally have fractional excretion of urea below 35%, while patients with ATN will have fractional excretion of urea more than 50%. BUN creatinine ratio is a simpler and easier to remember method of differentiating prerenal AKI from ATN. Markedly elevated, meaning more than 20 ratio of BUN and creatinine is indicative of prerenal AKI, while normal range of 10 to 15 is indicative of ATN. The difference is due to the avid urea reabsorption by the proximal tubule, which is impermeable to creatinine. However, limitations of this formula cannot be applied to patients with increased BUN production due to administration of steroids, total parenteral nutrition, patients having tissue breakdown or massive catabolic state, and gastrointestinal bleeding. There's another method of differentiating prerenal from intrinsic AKI. This is what we call the diagnostic fluid challenge. Here, we give normal saline of 10 to 20 mL per kilogram. This is very useful in two clinical scenarios. One is when a patient presents with increased serum creatinine and a history and physical finding consistent with prerenal etiology, but you don't know the duration of the prerenal insult. Second scenario is when a patient presents with an increase in serum creatinine, but the cause is unclear. So after giving the fluid challenge, if there is a reduction in BUN and serum creatinine, and it indicates a prerenal AKI. If there is an absence of improvement in these parameters, and or if the patient develops fluid overload, it is indicative of intrinsic AKI. As a warning, this is contraindicated in patients with obvious volume overload or heart failure. Never do a diagnostic fluid challenge for these particular patients. Complete blood count is also useful in determining the underlying etiology of AKI. Example, if you see the triad of microangiopathic hemolytic anemia plus thrombocytopenia plus AKI, it is indicative of hemolytic uremic syndrome. Severe hemolysis, whether drug-induced or secondary to hemoglobinopathies, may result in acute tubular necrosis due to massive hemoglobinuria. If there's eosinophilia and or urine eosinophiluria, it is indicative of interstitial nephritis. Complement studies including the determination of C3, C4, CH50, and AH50 is also useful in determining underlying etiology of AKI. Low complement, or what we call the hypocomplementemia, is seen in patients with post-treb glomerulonephritis, shunt nephritis, and nephritis associated with subacute bacterial endocarditis. Other helpful tests like serologic testing for strep infection, like the presence of anti-streptococcal antibodies, is a diagnostic criterion for post-treb GN. Drug levels, such as elevated levels of aminoglycosides, are associated with acute tubular necrosis. Acute kidney injury may result from markedly elevated uric acid levels, which may occur in children with tumor lysis syndrome secondary to chemotherapy treatment of childhood leukemia or lymphoma. When is kidney ultrasound indicated? Kidney ultrasound is only considered when the etiology of AKI is unclear. It can document the presence of one or two kidneys. It can delineate kidney size, and it's very useful for surveying the renal parenchyma. It is also particularly helpful in diagnosing urinary tract obstruction or occlusion of the major renal vessels. In addition, it's also useful in differentiating AKI from chronic kidney disease. The kidneys in AKI are usually normal in size or enlarged due to inflammation or edema with increased echogenicity, whereas those in CKD, the kidneys are frequently small and shrunken. A kidney biopsy is rarely indicated in AKI. It should only be considered when non-invasive evaluation fails to establish a diagnosis. It's most commonly indicated to help guide treatment in patients with suspected acute GN in order to identify crescentic forms or specific vasculitides. For suspected interstitial nephritis or suspected lupus nephritis to classify the disease and establish the activity and chronicity. Therapy of AKI is not covered by this lecture, but it should address direct cellular injury, oxidative and inflammatory injury.